and would like to introduce you to Dr. Andrew Yu, who is an orthopedic surgeon who's been trained at UCSD. And we are very honored to have his time this morning to talk about approaches to hip and knee pain and what's in his head when he receives a patient as a referral from me or other doctors for the evaluation of hip pain and knee pain. On a side note, I think Dr. Yu is going to be quickly within the next few years going to be the go-to orthopedic surgeon in San Diego. I know he doesn't envision that yet, but from the reputation by word of mouth that I'm receiving, I have a feeling that he will quickly rise to become an expert in this arena. And we are very, very fortunate to have him here with us today. So with that, I turn the mic over to you, Dr. Yu.
Well, thank you very much. That was very kind, and I really appreciate everyone's time. I'm looking at the participant list, and I can recognize at least one of my patients here. So hello. I won't say the person's name, but hello, and thank you so much for joining, and thank you to everyone else too. My name is Andrew. I like to introduce my name. I like to introduce myself as Andrew to all my patients, so you can call me Andrew or Dr. Yu. I prefer Andrew. I'm going to talk about the approaches to hip and knee pain and kind of focus a little more on the hip side. And I want to keep this very informal. I think we're going to keep questions for the end just for confidentiality purposes. But once we finish, I am more than happy to spend as long as possible talking to you guys. But to get started, I wanted to tell you a little bit more about me, and that all starts with these kids. Plenty of my patients see pictures of my kids who are really the true joy of my life. My oldest son, all the way in the back, is Tristan. He's 7. The wild man up in front is Sawyer. Everyone's currently at his Sawyer's baseball game right now. And then the little guy, the little blondie, sort of in the middle, is Parker. And they are just the most amazing trio of kids. They're happy, healthy boys, and we could not be more blessed to have them. And they're just a hilarious bunch. None of this in my life is possible without my wife, Taylor. You can see her there. This is the whole family at dinner. Kids are going crazy. Taylor taught for almost 8 years at the Bishop School and is currently staying at home with the 3 boys and infinitely busier than I am. And I am absolutely indebted to her. And just one more picture of the kids. On the left is Tristan. He's the oldest. In the middle is Parker. And then on the right is Sawyer. So thank you guys again. I was born in New York. I went to Williams College in Massachusetts for undergrad, then went down to NYU, New York University in Manhattan in New York City for medical school. And then my wife is born and raised in LA. So after medical school, we really wanted to come out to the West Coast. So I was fortunate enough to do my residency at UCSD, where I trained with Dr. Ball doing total hips and total knees. And then I did a year of specialization training at the University of Texas, Houston, which was an amazing year. The weather was not great, but our family was really, really, really happy in Houston. But we're also much happier to be back here in San Diego. So what do I do in surgery? Mainly my focus is total joint reconstruction. So that's total hips and total knees. When I do total hips, it's predominantly, truly at this point, 100% anterior approach total hip. Unless I'm doing a revision. When I do revisions, it's 90%. I use the standard posterior approach. It's a little more extensile. In addition to total hips and total knees, I do a lot of total knee replacement, or in addition to anterior hips and revision hips, I do robotic total knees as well as non-robotic total knees, as well as partial knees. And when I do partial knees, that's almost always using a robot. So this is really the focus surgically within my practice. But what do I do in clinic? Although the subspecialty focus is on hip and knee replacement, I do plenty of non-surgical things. One big part of my practice is injections, whether it's corticosteroids, hyaluronic acid, or PRP, or platelet-rich plasma. I do plenty of non-operative management techniques such as physical therapy, truly just education and guidance, casting, splinting, medications, getting people involved in other specialty clinics. I take care of trauma. So someone breaks their hip, breaks their wrist, breaks their ankle, I take care of that a lot. And truly, I see everything. So although I'm a subspecialist within the total joint world, I see patients with neck pain, with low back pain, with shoulder pain, elbow pain, wrist pain, and I'm very honest with my patients when I see them that you're trained in orthopedic surgery. I have somewhat of a foundation in the elbow or the wrist, but I'm definitely not a specialist. I'm not an expert, but my job in those situations really is just to aid in your treatment, whether it's getting you with the appropriate referral. And kind of when you come in, I have a lot of friends and colleagues within this world, and I can really direct you in the right direction more effectively. But again, the subspecialty focus is hip and knee replacement. This is my email address if anyone wants to take a screenshot. I'm extremely responsive to all communication. I love my job, and I love what I do. And so I bring that energy every day to work, and I would love to hear from any of you guys. You can use this to ask me a question. You can use this if you want to come in and see me in clinic, or if you just want feedback about something. So what do I think about when I see a patient? And so we're going to talk about this patient right here. This is a 75-year-old who came to me with right hip pain. He actually has severe bilateral hip pain, but it was worse on the right. You can see this is an x-ray of his hips, his pelvis, and his two hips. And he had a history of a femoral neck fracture on the right side. So you see those 3 screws going up into his femoral head. But the thing that I zone in on the most is the hip joint. I don't really have a marker here, and I'm not sure if you guys can see my let me see if I press this annotate button. Spotlight. Let's see. It's okay. Well, the hip joints have no cartilage anymore. The hip is a ball and socket joint. I don't know how to use a laser pointer here. Maybe here. There. So right in here, I'm drawing. So I'm looking right in this area. There's no cushion between the femoral head and the acetabulum. And so basically this guy has bone-on-bone arthritis. And so I see a lot of this, and this is what I've trained for years to take care of, whether it's in the hip or the knee. And so what I wanted to talk to you guys today is, when I see something like this, what's going on in my head, and how do I think about it? How do I go to the next step? And then let me see. I got to there we go. Oh, uh-oh. So I'm gonna have to erase that so it's not on every slide. Sorry, let me erase this. Okay, so when I see something like this, when I see bone-on-bone arthritis, it's almost always degenerative arthritis. And when I say degenerative osteoarthritis, I'm talking about pure wear and tear. The cartilage in the joint has been worn down over the years. It's 100% not a real disease in the setting of something like an infection or something like cancer or something like rheumatoid arthritis. It's just the body has worn itself out, and that's okay. However, sometimes it can be an autoimmune condition like rheumatoid arthritis or psoriatic arthritis. These are conditions in which your body actually attacks itself over the years. Your immunity is recognizing your own body as something alien, something foreign, and tries to attack it. And medications are great for things like rheumatoid arthritis and psoriatic arthritis. But we still see plenty of degenerative hips and knees in the setting of rheumatoid arthritis, for example. Sometimes arthritis like this can happen in the setting of what's called avascular necrosis. That's when the blood supply to the femoral head actually becomes compromised. And when the bone dies, the blood supply to the overlying cartilage leaves, and then the cartilage erodes and dies. And that is another cause of bone on bone arthritis. Sometimes it can be in the setting of trauma. So this patient had a femoral neck fracture. When you fracture your bone, you can compromise the blood supply to the adjacent bone. That bone can subsequently die, and the overlying cartilage dies. And some patients are born with hip dysplasia. To put that briefly, their hips just don't form correctly. And then mechanically, over time, if that's not corrected early on, that can predispose patients to hip arthritis. But when I see a patient like this, 95% of the time, it's osteoarthritis, a degenerative condition where the cartilage just wears out. And so, what is really the cause of this, of degenerative osteoarthritis? Overall, this is just wear and tear. It's just over the years, the cartilage has worn out. And this can be influenced by your diet, your genetics. It can be influenced by trauma, by weight. But truly, it's a multifactorial problem. But it's degenerative. Your body has worn out over time. And, my job is not just to fix it or, reconstruct it or treat it, but it's also to educate. And I have some patients who all they need is for me to tell them that it's a degenerative process and it's not a disease. And if it doesn't hurt you, you don't need to do anything about it. If someone came into me with x-rays like this, and they were fully functional, they didn't have any pain, you don't need to treat degenerative arthritis. It's only when it's painful that it becomes a big problem or it interferes with your quality of daily life. But if I saw this patient who had no pain, I wouldn't recommend medications. I wouldn't recommend surgery. With medications, with surgery, there are risk factors, there are complications that can happen. So, we're treating the patient, we're not treating the x-ray, and that's really important to me. So how can I help in this setting? Again, number one is education, talking to patients about hip replacements, talking to patients about injections, talking to patients about weight loss, about medications, about physical therapy, and even just defining and diagnosing the problem often gives the patient peace of mind and, just creates a better relationship between me and the patient. But I wanted to start by talking about weight loss because this is one of the things that comes up a lot, particularly as we're taking the next step for surgery. The biggest point I want to get through is when patients are overweight, losing weight is not just good for your joints, it's also good for your life. It's not, when I'm asking patients to lose weight, it's not just for the benefit of their hips or their knees, it's good for their heart. It's good for their kidneys. It's good for their lungs. It's good for their brain health. It's good for their overall longevity. And ultimately, that's the most important thing, not just the hip, not just the knee. Around the time of surgery, though, weight is a very important issue, not just to me, but truly for the patient, because improving weight will decrease one's chance of a complication. So not only do I treat primary hips or primary knees, not only do I do hip and knees for arthritis, for example, but say some patient has surgery elsewhere and it gets infected or it gets loose or they dislocate or it fractures. I take care of a lot of those more complex problems. And I see a lot of these complex problems in the community. And, when total hips, for example, do well, they do extremely well.
It's about,
When total,
it's written
total hips,
now, but it was set in like early 1800s,
Sorry
late
about that. I'm
1700s,
gonna
and it's
okay,
about this
have you
British
pause for a
woman
second.
in the aristocracy,
sure.
maybe she had a flame with some.
Make sure everybody's muted.
So when total hips do well, they do extremely well. But when they fail, they do very, very poorly, and I see that. So it's in the patient's best interest to become the best surgical candidate they can be, and improving weight truly, truly improves one's chances of a better surgery and decreasing potential complications. And I have plenty of patients who need to lose weight, and I just want to be crystal clear that if I tell someone I need you to lose weight, I will stick with you in this process. I often do weight checks every 2 to 3 months. Referrals, I make referrals to weight loss specialists that we know very well and we trust. Um, I'm here not necessarily as a surgical specialist or physician, but as a mentor, as a friend, as someone who can help motivate you. And then finally, by truly defining the risk around surgery in the setting of weight. So, there are patients who I've operated on who are maybe not below the threshold where, the risk is, very low, but they're in such severe pain or they have truly such a big problem that we can't wait. And I've taken care of many of those patients, and uh, they've gone on to great outcomes. And so just being overweight doesn't preclude anyone from surgery. It's a discussion of risk. And if everyone is on the same page that, there's a risk factor and we're okay to proceed because someone's in severe pain, I would never refuse anyone care. Of course not. Um, Another facet of what I do is injections. This is a big part of what I do in clinic. And that's three categories. One is a corticosteroid injection. That's often mixed with Toradol. Toradol is like an IV Motrin or a IV Aleve. It's an anti-inflammatory, and I often mix that with lidocaine as well. That's in a local anesthetic medication. Another type of injection I do is hyaluronic acid. That's only authorized or covered by insurance for knees. This is often marketed as a gel or a lubricant. And I just wanted to share with everyone that it is not. It acts very much or similarly to a corticosteroid. It works as an anti-inflammatory, but it's not a cushion, it's not a buffer, it's not a gel, it's not a lubricant as it's often marketed. Does it work? Absolutely. But it works like a steroid as an anti-inflammatory. And then at the bottom, I write platelet-rich plasma, and we'll get back to that. I have a slide on that later, sort of the way I go through it with patients. So we'll come back to PRP. So, patients have ongoing pain despite therapy, despite medications, despite injections. Truly, in the setting of degenerative end stage bone-on-bone arthritis, the solution, the long-term solution to the problem is a hip replacement. I will say that a hip replacement is my favorite surgery. I think the outcomes that we can achieve with them are absolutely amazing, and it is so wonderful seeing the patients the next day or right after surgery or 2 weeks out or 6 weeks out and monitoring their progress, because it's one of those surgeries that can really be night and day. And this is something that really brings joy to me, because you see these patients come in with big smiles at the 2 week mark, and it's so satisfying to be able to offer this service. Plus, these are surgeries that I think are very fun, and I think that's important for you guys to hear, because it makes me want to be the best total hip surgeon in not just San Diego, but Southern California and the United States, because these are great surgeries. They're fun to do. The anatomy is amazing, and to continue to
I'm listening.
try and be better to develop the art of
We
surgery.
Sorry, sorry. I'm just going to remind everybody to please mute your screens so that Dr. Yu can be heard. Thank you.
And so, for example, I do plenty of elective total joints on Saturdays for patients who need to get in very quickly. And I'll up and walk in, and the patient is just, almost apologetic that I'm coming in on a Saturday. And I have to explain to them that this is not something that is almost like a job. It's not like a to do. This is fun. I get to come in and, do the craft that I've trained for years to do. And I find joy and satisfaction in that. And so basically, I just want to convey how much I love my job and how much I think total hip replacements are amazing surgeries. So within the realm of total hip replacement, there are three main approaches to the hip: an anterior approach, a posterior approach, and a lateral approach. And the final product generally is the same. The approach is just how you access the hip joint from around the femur. I do an anterior approach, which I at this point consider to be by far the best approach to total hip replacement. And I think generally most people now in the United States and the world agree with that. It is truly the most muscle sparing approach, and I think it generates the best outcomes. That being said, a posterior approach is kind of the original gold standard. That was the original approach to the hip. It does cut muscle, but it is a great approach. When I trained at UCSD under Dr. Ball, he was a specialist in the posterior approach, and he did an excellent posterior approach. You guys are probably familiar with Dr. Scott Ball's name. He's a big reason I moved from New York to San Diego to train with him. And he is, much of the reason I went into total joints as a resident. It was, even before I learned that I loved total joints, I saw Dr. Ball as a mentor and just a good person. And that really just influenced me to do what he does. And I am so happy with that decision. Finally, there's a lateral approach. And not to speak ill of any approach, but the lateral approach, there's a reason it's not really done anymore in the United States. It really compromises muscle and tendon. And I just think for the patient's best interest, lateral approach, if you're offered a lateral approach, maybe you should think twice about proceeding with that surgery or that surgeon. I've seen too many poor outcomes after a lateral approach. But again, I'm sure it can be done well. But in general, these are the three approaches. I love the anterior approach. I use that for 100% of my primary surgeries, and I think it truly expedites patient recoveries. So what are the benefits? Again, the anterior approach is one approach to the hip joint where no muscle is cut. And I cannot overstate the benefit of that. That leads to earlier recovery. That leads to less bleeding, less inflammation. When you do a posterior approach, you have to be very strict about how you move your leg after surgery. If you flex it up too far, there is the potential that it can pop out the back because you're disrupting the posterior tissues of the hip. When you do the anterior approach, you do not have any of these precautions. And that's just one less thing for the patient to worry about. And for example, sitting down on a low toilet seat, sitting down on a chair, crossing your legs, these are very, very common activities to do in daily life. And to have that increase the risk of a posterior dislocation is a big risk, if we're talking at the population level. So anterior approach certainly has a much lower risk of hip dislocation. When we do the anterior approach, where we use a very specialized table, we have patients lying on their back versus on their sides when a posterior approach is done. And so using X-ray during surgery, we can get a much better look at what's actually going on in the hip while we're doing it. And so that allows us to put in components with better size, better rotation, better angulation, and then it helps us minimize limb length discrepancy. So it's very rare to have a limb length discrepancy after the anterior approach. Overall, you have a smaller incision in the anterior approach, and I'm not a proponent necessarily of minimally invasive surgery, but I'm a very big proponent of being extremely soft tissue friendly, and being very kind of conscientious about protecting the surrounding soft tissues. And we're able to do that very well in the anterior approach by going between different muscles, but not actually cutting any muscles. And I think when you take all of this together, the anterior approach does allow an earlier recovery overall. So back to this guy, he had severe bone on bone arthritis on both sides. On his right side, he additionally had a history of a femoral neck fracture, and therefore you can see those screws in place. I actually took care of both of his hips, starting on the right side. The both were done anteriorly. He went on to an absolutely amazing outcome. He's extremely happy. This is a very healthy, fit guy, and he's back to everything he wants to do. Has no pain, and he's it just seeing him walk in a clinic. Whenever I see him, it is so satisfying to be able to deliver this product and really just help him with his quality of life. So I've got a slide on platelet-rich plasma. And then after this, I can answer any questions about hip replacements or hip pain, hip arthritis. But I knew there were some questions about platelet-rich plasma, and I wanted to give you my honest opinion of PRP because it's a little controversial. So number one, does the current research suggest it works? And I think that is a resounding yes. Platelet-rich plasma does work, but do steroids work? Yes. Does hyaluronic acid work? Yes, absolutely. They all work. The thing with platelet-rich plasma is it expensive? And the answer to that is also a resounding yes. PRP is very, very expensive. And does insurance cover it? No, insurance does not cover it. I think workers' compensation is the only insurance that will cover platelet-rich plasma. But to the best of my knowledge, no Medicare, HMO, or PPO insurance covers platelet-rich plasma. So this is a cash pay treatment option. And then another thing that I often talk to patients about is the fact of, or the question if PRP is regenerative. Platelet-rich plasma, at least in the setting of knee arthritis as well as hip arthritis, is absolutely not regenerative. The cartilage cells that are gone, and they're unfortunately at this point in our technology, they're gone forever. So no, PRP is not regenerating anything in your hip. Does that mean it doesn't work? No, it can work very well symptomatically, but it's not working because it's restoring your native anatomy. So how does it compare to steroids as well as hyaluronic acid? The research shows that it's at least equal, if not better. Okay. But it's way more expensive. And for patients who come in with severe bone on bone arthritis, I don't usually think that PRP is truly the best option for the exact reason that it's so expensive. Of course, if patients want to try it, it's certainly an option. I think it can help. It's a natural substance. It's coming from your own blood. And so it's not a foreign substance like hyaluronic acid or corticosteroids, but it's very expensive. And if it doesn't work, it's just a lot of money to part with versus a steroid or a hyaluronic acid, which is pretty much entirely covered by insurance. So to summarize everything, do I think it works? Yes. But in my practice where I'm treating many patients who have severe bone-on-bone osteoarthritis, such as this, do I think that PRP in a setting like this, would I go out of my way to recommend PRP? The answer in my situation right now is a resounding no. I think for people with moderate arthritis or tendonitis or rotator cuff tearing, is PRP a better option? Yes. Could someone with hips like this benefit from PRP? Sure, absolutely. Whether that result would give relief for weeks or months or days is so hard to say. But I don't want anyone being misled to think that PRP is regenerative or it's going to restore natural anatomy. Truly, at this point, the best technology we have for bone on bone arthritis long term is a hip replacement. For knees, it's a knee replacement. And then if injections are being considered, I will often recommend either a steroid shot or a hyaluronic acid shot over a PRP, specifically because it's covered by insurance. The moment insurance covers PRP, I would be happy to recommend that to everyone. And of course, most clinics now have the capability of doing PRP, but I think we all have to be cognizant how expensive it is, and that's important to everyone. So thank you guys so much for having me. this is fun for me. And if you guys ever want a discussion on something else, I'm more than happy to do a question and answer setting, or question and answer talk, or give another talk on a certain topic within the joint replacement world. But I really want to become the most trusted total joint surgeon in San Diego. I love my job. I truly do. I think at my clinic, I work at Grossmont Orthopedic Medical Group in La Mesa. My partners are amazing. Our clinic is amazing. It's a very nice clinic. I think we do exceptional patient care. It's a very happy place if anyone on this chat has been there with us. And I want to do that by earning your trust and really taking care of patients, whoever comes in. And that's not just to serve as a surgeon or a physician, but it's truly to work as a resource, as a mentor, as a friend to my patients. And many of my patients already have my cell phone number, and just they text me if they have a question, if they have an issue. I want to know immediately, rather than not hear about it and then be surprised later in clinic. And I think my patients really benefit from that easy access to me, and kind of my perspective. And then finally, this is an amazing profession, and an extremely fun profession, but it's a very humbling profession. I take care of a lot of, particularly in the revision setting, I take care of a lot of patients who are sick, who are elderly, who have very major medical conditions. And when things don't go right, it haunts me. But it also it drives me to become better and better. But yeah, it's humbling. But I love what I do. I think I recognize some of my patients on this chat now, and I'm open for questions. And thank you, everyone, for your time.
Well, thank you, Dr. Yu. And it's wonderful to have this presentation. And I know we're going to have lots of questions. I'm going to go ahead and stop the recording, but you are definitely on your way to being one of the most trusted total joint surgeons in San Diego County. I didn't even know this was on your slide when I introduced you. Um, so I think it's wonderful. So I'm going to go ahead and stop the recording, and then there's some questions in the chat, and then I'll open it up to the floor.